First and foremost, when you are applying tape, the very first thing that you need to figure out is your intention. Now, there are 3 possible intentions with physical therapy no matter what you're doing. The first one is neurological, the second one is chemical, and the third is mechanical. There are literally 3 ways that you can actually impact a person's system. So with taping, it's actually no different. If I'm going to apply tape for a neurological intention, then the 2 probable intentions I'm going to be using are either to reduce pain or to increase proprioception. Tape applied for those 2 reasons is considered a neurological tape application. The next tape application is you can actually apply tape to help reduce swelling. So that would be a chemical intervention using tape. And the third application that we could possibly use tape for is actually a mechanical intervention, which is what most people think of when they think of taping. They think of like blocking motion. So the kind of tape that you use and how you apply it depends upon which of those 3 intentions you have. Whether you're trying to make a neurological change, a chemical change, or a mechanical change. I would be going into each of those a little bit more. So with a neurological change, so let's say we are looking to reduce pain, we don't necessarily need to grab like Leuko tape or anything too rigid, because if I do that, it's going to be pulling on the skin a lot. Like just a nice flexible K-tape does just fine, because the idea behind pain reduction is that we're actually trying to increase the proprioceptive or mechanoreceptor input through the skin and gate the pain at the dorsal horn. So when you're doing that, it's kind of like rubbing a boo-boo, right? When you put tape over an injured area, it feels better. So with that in mind, K-tape works really well. For proprioception, however, when you apply K-tape, which is very flexible, to somebody's skin, after about 10 minutes or so, they don't feel the tape anymore. And the reason is that the tape is too elastic. So if you're trying to get proprioceptive input, K-tape is great if you're going to do it just for a few minutes. After that, it kind of stops working very well. Then you have to start thinking about using something more rigid like cover roll, or even going with some kind of expensive product like dynamic tape, which is more rigid than K-tape but less rigid than Leuko tape. So dynamic tape is really good for the proprioceptive stuff. For swelling, the chemical input, K-tape works really well. Now, the reason is that when you're applying something for, and you said before we went live here that you didn't even know that tape could be used for like a chemical change, right? So I have a couple of pictures, I'll try to put them in the description or something, of a patient who had a bruise. I did a spider tape with K-tape over the bruise, and then when I removed the tape, literally where the tape is over the bruise, that bruise is gone. And where the tape isn't, there's still a bruise. So we know that something is happening when you apply K-tape to the skin. The theory is that what the tape is doing is it's actually lifting the skin up a little bit or puckering the skin. And where do all the superficial lymphatics live? Right under the skin. How does lymphatic drainage work? By manipulating the skin. So the idea here is that you're applying the tape with the intention of affecting the superficial lymphatics by puckering the skin. So now let's think about that for a second, which brings us to our next sort of like topic, which is preposition. So if I'm going to apply tape over his knee and I'm going to do K-tape, do I want his knee in flexion or do I want it in extension if I'm applying K-tape over the front of the knee in order to reduce swelling? Here's the way to think about it. I don't know if you guys can see. Andrew's got black pants on, but I want you to just straighten your leg out. And you'll notice that his pants start to pucker. See how the pant leg puckers? Maybe you can see it on mine. You see how here we get like puckering in the pant leg? The general idea here is that when you're applying tape for swelling, you want to create that puckering effect. So if I was applying tape to block motion or support his quad, I would pre-position the leg in extension, tape over the leg so that when he bent the leg, the tape goes on stretch. But if you're applying it for a chemical reason to reduce swelling, you do the exact opposite. You flex the knee, you put the tape on. Now, when he extends his leg out, all of the tape is going to start to pucker. And when you see the puckering in the tape, that's how you get that chemical change when you're working on bruising and lymphedema and stuff like that. So that's the chemical stuff. And then for mechanical stuff, preposition is really important. So let's just say for 1 second, I wanted to tape, let's do the arm here because it's easier to see. Let's say I wanted to support his biceps. So if I apply the tape, I need to apply it across the joint from the front of the joint right here to block extension of the elbow. Let's just say that was my goal for now, right? If I have so a lot of people think that it's just the tape tension that matters. No, as you put the tape on, it's how hard you pull the tape. But it's not. It's mostly the preposition of the arm. So if I put his arm in this position and I tape, you'll notice that the tape is going to go on stretch only when he gets into full extension. But if I put him in this position and apply the tape is going to go on tension when I'm here. So if I apply a rigid tape, like Leuko tape, and I put his arm in this position, I will literally block his ability to straighten his arm, which probably isn't a good idea because he's probably going to get an elbow flexion contracture. But if that was my goal, right? If I use K-tape and I put his arm in this position, he will still be able to extend his arm because the tape is flexible. So you have to understand whether you're trying to tape for a neurological, chemical, or mechanical input. And if you're doing mechanical, which means you're trying to block or support motion to either stop an ankle from re-spraining or hold someone in a corrected position, it's not just the tape tension that matters. Oftentimes, if you're trying to get a mechanical change, you're using a more rigid tape. It's the preposition of the joint that matters most. Does that make sense? Yeah. Okay. The next component is anchor. So when we're taping, the anchor is important. Now, the reason that the anchor is important is because the size of the anchor determines how much you're going to dissipate force. So if I'm going to apply a piece of tape over here, and let's say I'm going to wrap it around the backside, if I just start the tape right here, a really small anchor, every time his scapula starts to protract and that tape gets put on tension, and the anchor is really, really small, all of the tape pull is going to go into the skin, into this tiny little anchor. And there's way more of a chance of you developing a rash or blistering because the anchor is too small. So the concept is when you're applying tape, is one of the principles, you want to get that anchor as big as possible so that you're distributing that tape force over the widest surface area. The bigger the surface area, the more comfortable the tape is going to be, the less likely you are to get skin irritation. So that's the principle of the anchor. We talked about tension. The next component is axis. So when you're applying tape, the axis of rotation of the joint is going to determine whether the tape goes on stretch when the joint is in extension or flexion. So for example, if we look at the elbow, right? If I apply a piece of tape down Andrew's arm on the inside and I cross his elbow, but I cross anterior to the joint line, when his elbow goes into extension, I'm going to get tape tension. When his elbow goes into flexion, I'm going to get less tape tension. If I took that exact same piece of tape and I accidentally applied it posterior to the joint line just a little bit, the exact opposite phenomenon occurs. When I extend the arm, the tape's going to go on slack, and when I flex the elbow, the tape's going to go on stretch. So you have to be very mindful, particularly with hinge joints like the elbow, the knee, the ankle, when you apply the tape, whether you're applying the tape anterior or posterior to the joint line will determine whether the tape is on stretch or slack, depending upon whether they're in extension or flexion. If you apply the tape directly over the joint line, half of the tape will be on stretch when they're in extension, half of the tape will be on stretch when they're in flexion. So that gives you sort of the best of both worlds. So if you're trying to create stability to, let's say, a ulnar collateral ligament, and you're taping over the medial elbow, and you want some stability into a valgus force when the elbow is straight and flexed, you actually need two pieces of tape. You need one anterior to the joint line that's going to operate when the arm is in extension, and one posterior to the joint line that's going to operate when the elbow is in flexion. So that's a principle that you need to follow when you're trying to support a joint. You have to understand whether you're in front or behind the axis will determine when that tape goes on tension. Make sense? Okay. And the last one is a taping false belief. And I will tell you right now that the direction that you apply tape makes absolutely no difference. Again, the direction that you apply the tape makes no difference. This question came up when I did a video a little while back about Dariana came in and she had an ankle sprain. And I was taping her ankle, and I was taping it from the peroneals, wrapping it down underneath and hooking the heel. And one of the PTs in the PHYSIOSecrets group asked a really good question. He said, why didn't you tape it the other way? It looks like you're taping him from, the proximal to distal. Why didn't you hook the heel and pull her into eversion? Isn't that going to change the proprioception? And the answer is no. And I'm going to show you why. So if you take a look at the rubber band, if I apply the rubber band to my fingers, I'm going to span right across my fingers here. If I pull from my thumb to my pinky, as I apply the rubber band, I can sense that my thumb is getting pulled more than my pinky, that the tape, the pull has directionality. Conversely, as I'm applying the rubber band from my pinky to my thumb, then that proprioceptive input matters too. I can feel my pinky is getting pulled, then I hook onto my thumb. But what happens after I let go and the tape is applied? You will notice that the rubber band pulls from both sides equally, and I, proprioceptively, cannot tell whether I hooked it onto my thumb first and then my pinky, or my pinky and then my thumb. after you apply tape, once the tape is applied, the tape pulls on both ends equally, and you cannot tell, once the tape is on, which direction the tape has been applied. And that is a really important concept because direction of taping is sort of like taught by the K-tape people of whether you tape proximal to distal, distal to proximal, origin to insertion. It makes no effing difference. You cannot feel the difference after the tape is on you. You can only feel the difference while the tape is being applied. So that's really important because how then do you determine which direction you tape somebody? And the answer is in the direction that is more convenient. So if you think about it, when you are taping something, you have to be aware of where the tape is going to start and end. I'll give you a really good example. Let's say I'm taping Andrew's periscapular region, and I want to hold his scapula into a bit of retraction, right? So am I better off starting the tape on his backside and wrapping it around to the front, or starting on the front side and wrapping it around to the back? What do you guys think? Back to front or front to back? So here's the thought process. If I'm applying the tape, he's got chest hair, right? Yeah, probably too much, right? So if I apply the tape from back to front and I put some stretch on the tape and I start to wrap it around, but I've miscalculated where the tape's going to end up, I'm going to end up right on top of his chest hair. So guess what's more convenient and smarter? For me to start the tape in the front, lateral to the chest hair, and then wrap it around the backside. Because I don't care which direction it's pulling in, because when I apply it is the only time he's ever going to feel that. The moment I let go, all he feels is this is getting pulled to this. He does not know which direction I taped him. So whenever you're applying the tape, you want to try to figure out what is the more convenient direction to apply the tape so that when I end my tape, I end up in the spot that I want to end up in. Because once you let go, it doesn't matter. Okay, so those are the basic principles of taping. Now let's go ahead and let's get this tape job done. So Dan Lin asked, how would you tape a finger to avoid hyperextension? So this is a little bit like when Betty Crocker, pulls the cake out of the oven and shows you the finished product. We're going to try to get this tape job done. And this is a super simple tape job, and I just want to go over the principles. So I'm going to retape his right hand, and I'll tape his index finger so you guys can see. I'm going to tape him with athletic tape, just because it's easy for me to rip, and you guys can get a sense of what the concept is here. So here's how it goes. I want to tape his interphalangeal joint. And in my hypothesis here, he had a hyperextension injury. So I want to block extension, but I only want to block extension for a couple of days because I don't want to give him a finger flexion contracture. So let's just say I wanted to block him like this. He comes off the basketball court, his finger's aching him, he had a hyperextension injury, and I just want to stop his interphalangeal joint from hyperextending. Let's just say. So what I want to do is keep the joints above and below his finger as free as possible. And I want to apply the tape such that I'm going to anchor just above the joint I'm trying to block and just below the joint I'm trying to block. I'm trying to make a mechanical change, not neurological, not chemical. So I'm going to pre-position his finger in the position I want to keep it, apply the tape on the correct axis, which means on the anterior palmar side of his hand, not the dorsal side, so that when he goes into finger extension, the tape goes on stretch before his finger flexor does, or before his finger tendons do, so that I protect the stuff on this side of his finger joint. So I'm going to do this really crudely just so you guys can see the concept here at work. So take my athletic tape, I'm going to get a couple little strips, I'm going to set those down, and sometimes it's helpful to prep what you think you need beforehand. So I'm going to do that. So I have anchors, I have my finishers, which are going to go at the very, very end. And then I'm going to have my little straps that are actually going to block the motion, which I'll make a little bit shorter. Good. Okay, Andrew, let's get that finger over here.
All right.
So what I want to do is I want to straighten his finger out, and I want to, let me squat down here, and I want to do it so when I get these anchors on, I want to do that with the finger relatively straight because I'm not worried about the preposition yet. I'm going to apply anchor number 1. I'm going to try to get that anchor right at that middle phalanx so that I'm not blocking his distal phalange motion. So boom, that's number 1. And I'm going to get this guy below the joint line here. And that's anchor number 2. Hopefully you guys can see that. So we have 2 little anchors there. And that's one of the reasons I hate athletic tapes, because you always get these little strings that kind of bug you. Okay, so that's my anchor. So now I'm not going to anchor onto his skin. Athletic tape doesn't stick to skin very well anyway. So now I'm going to use my support strip. When I apply my support strip, I have to basically get it so that it fits between this point and this point. So that's why I use athletic tape here, just so it's easier for me to show you guys. And I want to pre-position his finger in the position that I want to keep it in. So if I give him a bit of flexion, now I know the tape's going to stretch a little bit, so I'm going to flex him a little bit more. And then I'm going to apply the tape across my 2 anchor points. Boom, boom. Right there, and get it nice and taut. Now, given that this tape is like not the best tape in the world, I would really do this with Leuko tape, but because I can't tear Leuko tape, I can only cut it. I'm using athletic tape just to show you guys. But you would do this with Leuko tape, and you can do it right to the skin because the type of skin that's on the hand is very resistant to irritation. Use your hands all the time, so you're not really going to get any rashes or blisters on the skin from taping. So those are my 2 anchor points. Now I'm going to test the amount of tension that I have. So slowly try to extend your finger. And we'll see the tape goes on tension there. So that's exactly the position that I want that tape to go on tension. I'm just trying to block end range motion. And then I'm going to put my anchors on there and then check to see, make sure his distal phalanx still moves. And I know that his MCP joint still moves. I'm going to put my anchor on there. Boom, boom, boom. And then if I wanted to clean this up, I would just trim the little end point that's there. So you can see that his knuckle is still exposed. His finger flexes, but it does not extend anymore. He's still got motion in his distal phalanx, and he's still got motion in his MCP. So that's the finger tape job. So that's number 1. So that was taping the mechanical principles. Now let's do a neurological tape job, and let's do it for the cervical spine. So go ahead and turn around. We can back up this way a little bit. So one of the most important neurological cues that we like to give people when they have let's say a disc derangement in their cervical spine is we're going to ask them temporarily, at least for a couple of days, to stop looking down. Now, one of the things that we're trying to get them to stop doing is looking at their phone, reading books like this, and essentially deranging their disc in their neck by just continually looking down and forcing the disc material posteriorly. So what I want to do is I want to stop Andrew from looking down. I want him to understand and learn the number of times that he looks down throughout his day, at his watch, at his phone, at the dishes, at, when he goes to the bathroom, like the number of times he does cervical flexion compared to the number of times he extends his neck, it's no wonder he's got a disc derangement. So I need a neurological change in his behavior. To do that, I need to apply a tape that gives him feedback so that when he flexes his neck, he understands not to do that. Now, you know what? Let's do this. I'm going to K-tape you first and see what that feels like to you. So when I do K-tape, by the way, guys, I don't round the edges. I find that to be terribly annoying. I'll show you what I do instead, is I just cut the corners like this. Essentially just cut the edges. It does exactly the same thing. Okay, so let's K-tape them. Now, you might say, well, the direction of tape matters. It matters whether you tape from the bottom up or the top down. Nope. It doesn't matter at all. So what I don't want to do is I don't want to end up in his hairline. So I'm going to tape from the top down. By taping from the top down, I ensure that I'm going to finish at the bottom. I'm not going to tape from the bottom up. Then I might accidentally cut a piece that's too long and end up in his hair. So K-tape, you're going to break the tape with a decent size anchor. So they say at least a 2-inch anchor. And I'm going to apply this. Look straight ahead for me. Just under his hairline here. Now, when I apply the anchor, there is absolutely no stretch to the tape, and there is no stretch to the skin. You want to apply the anchor with no tape stretch and no skin stretch. So that anchor is on pretty good. And if you want to get anchors and tape to stick, you need to heat the tape up. So the way you heat the tape up is just with your finger, or you can use a scrap piece of tape like this. You can use the backside of your tape. Some people will use this to kind of rub it. If you heat that tape up a little bit, it sticks a lot better. Okay, now, let's just say for 1 second I taped him in a neutral position, a neutral pre-position, with no tape stretch, and I just laid this tape on. He wouldn't feel anything. And he wouldn't feel anything until he bent his head all the way forward. That's stupid, because I want him to not do that. So you might say, well, one option would be to apply tape stretch. If I apply tape stretch, he's going to feel the tape all the time. Now, what do you think would happen, Andrew, if you felt the tape all the time? Would you pay attention to it, or would you not pay attention to it?
I'd probably pay attention to it at first, and then it would just get used to it.
That's right. You get used to it. You habituate is the term, right? If you put your clothes on, you have an itchy sweater on, at first you feel it, but later on you don't. So if I apply tape stretch and lay this tape on like that, it's now going to pull. That's interesting. Watch. You can actually see this. When I apply the tape, look, see how it's directional, the pull? Watch what happens when I let go. I don't know if can you guys see that? It's actually pulling from the top down and the bottom up. So it's doing the same thing the rubber band thing did. So if I apply a lot of tape stretch, lay this tape on and put it down, he's going to feel the tape stretching, but it's going to stretch constantly, so he's not going to know not to bring his head down because it always feels like the tape is pulling. The other option I have is to have him tilt his head back, pre-position, and then tape. The problem is you can see that just creases up here. I don't actually get it, so I extend your back a little bit. But now I get periscapular waist. That's no good. So let's do the tape stretch piece. Get some tape on stretch. Come down here. And then I'm going to apply my anchor with no tape stretch whatsoever. Let's heat the tape up a little bit. Okay. Now, let's pretend this is your cell phone. Hold that.
Okay.
And look down at your cell phone for me. Okay. You feel the tape pulling, yes?
Yes.
Okay. Now, can you still look at your cell phone?
Yeah.
Okay.
I can.
All right, now here's what's going to happen, right? Let's say for 1 second he disobeys the tape. He disobeys the tape, disobeys. With K-tape, because it's flexible, guess what happens to the tape? It stretches. So once this tape starts to stretch out, he's going to feel the tape less. In addition, because he feels the tape all the time anyway, there's no like on off, like I feel it, I don't feel it, I feel it, I don't feel it. So he's going to start to ignore the tape. So while this is a decent anti-flexion tape job, it's not the one that I prefer. One, because they start to ignore the tape job, and two, because as he looks through the tape, this is K-tape, it's going to start to stretch, and then he will stop feeling the tape as a whole. Okay, so decent application, but not preferable. Neurological intention here. All right. What I prefer instead, and I have really not seen very many physios using this, but this is an absolute hack and probably one of the best hacks with tape I've ever figured out, is this is cover roll. This is the same cover roll that you would use when you're using it underneath Leuko tape. But guess what? I use cover roll with almost every single tape job, and I almost never use Leuko tape, and you are going to see why. I'm going to measure the same piece of tape from here down to about here, same distance. With cover roll, make sure you fold it backwards, so you've got this little loop, and then when you cut it, it cuts much easier. And make sure you cut in the base of your scissors, not the front of your scissors. If you cut in the base of your scissors, the glue from the tape doesn't come off. If you cut in the front of your scissors, it does. No need to trim the edges, although you could if you wanted to. And you don't break the tape, you peel the tape. Okay. Now, one really cool thing about this tape is that it is porous. There we go. See how it's porous? Now, the reason that's important is because every time he showers with this tape, he will dry. It will dry, and he will not get water trapped under the tape. If you take this and you cover it with this, you trap the water underneath there. That softens the tape up. It stops becoming as rigid, and it wants to fall off. So by using just cover roll and not Leuko tape on top of it, you're going to get a nice good block to motion. It's breathable, so it's very well tolerated, and you can wear this up to 5 days with very little to no skin irritation at all. And it's going to give me what I want, which is no feedback when he's in the corrected position. Only feedback when he's in the poor position. Do you understand why that's more valuable? Because now his neurological system doesn't get used, there's no habituation. He only feels it pull when he's in the bad position. He doesn't feel it pull when he's in the good position. All right, here we go. So look straight ahead for me. Good. I'm going to go in the same exact spot I did before. There's my anchor. Okay, again, I got a 2-inch anchor. I'm going to try to heat the edges of the tape up a little bit just so I make sure that they stick really nicely. I'm going to peel this off. Now, this is cover roll. By the way, I don't actually call this cover roll. I call it posture tape because I use this for posture taping 99% of the time. And when patients ask me what is it, I say cover roll. It's kind of a stupid sounding name, so I just say posture tape. But watch this. Okay, chest up, looking nice and good. Yeah, don't squeeze your shoulder blades back too far. Yep, I'm just going to lay this tape on with no stretch. That's the key. There's no stretch on the whole tape. Now, the reason that's important is, do you feel the tape?
Right now?
Yep. Like, you know you have tape on you, but do you feel it pulling?
No, not at all. Not really.
Okay, so he's in good posture and the tape is not pulling. That's perfect. So now when he's a good boy, he gets rewarded by no tape pull. Okay, now slowly bring your head down. Stop when you feel the tape stopping you.
Yeah.
Okay, what do you feel now?
I feel the tape pulling.
You feel the tape pulling.
Yep.
Come to the corrected position. What happened to the tape pull?
Nothing.
Isn't that cool?
Yeah.
So when his head goes down, when he starts to look down, he gets a reminder that says, don't do that, dummy. Bring your head back up. Now the tape pull goes away. Now he does not habituate to the tape pull, which is the key to posture taping. So now we got this intermittent neurological signal that says, don't put your head down, don't put your head down, but only when he's putting his head down. And as long as your head is down, you feel the tape pulling, correct?
Oh, yeah.
And it's pretty strong.
Oh, it's crazy.
And it's not coming off, and you can shower with it. So I do this for the cervical, I do this for the lumbar, I do this for the periscap. This is gold right here. And we're going to do one more tape application, and we're going to use something called dynamic tape. And we're going to use dynamic tape to give you some periscapular retraction. Now, I just want you guys to see the difference in the tapes by doing this. We did K-tape. We saw that K-tape is really, really good for pain modulation because you always sort of have that input to the skin with the tape. It's really good for swelling and stuff like that. It's really not good for posture, and it's absolute shit if you're trying to actually support something because it has no rigidity whatsoever. We saw that athletic tape is really quick and dirty. It's really easy to apply, easy to rip, easy to put on, and it's cheap. The problem is that it doesn't really last very long. It's not really breathable at all, so it tends to get wet underneath when the person sweats, which means the tape becomes less sticky and basically falls off. So you know what this is really good for? Practice. If you want to practice taping, get some athletic tape because it's cheap, and you can practice all these tape jobs with the athletic tape until you get good at them, and then go get the expensive stuff. Leuko tape simply reinforces your concepts with your coverall. So if you can basically get a good coverall application, and I want it to basically block this thing so there's no way in hell he's going to move, you just apply the Leuko tape on top of it. So it's just essentially Leuko tape and this tape work hand in hand, but whatever you do with the posture tape, you can apply Leuko to stiffen it up. But bear in mind, when you apply Leuko tape, it's not breathable, so you're going to get water trapped underneath the tape when they take a shower. This tape tends to get really gooky when you shower with it, and then the person wants to take it off or it'll fall off. So, this will last about 3 to 5 days as well, but the tape starts to look really nasty. This tape, after 3 to 5 days, you'll actually notice it still looks like this. You don't get dirt trapped underneath it. It's just a very different experience for the person. It's much more comfortable. So the last kind of tape is dynamic tape. Let me tear a piece of dynamic tape. Notice it tears like the Kinesiotape, but you'll notice that it's a lot thicker. It's less porous, so you notice you can't really see through it. It has 3-dimensional stretch, and it's a lot stiffer. Watch when I try to stretch this tape out. That's as far as I can stretch it. Whereas with K-tape, you can stretch it out a lot farther. So we're going to do a periscapular application to hold those scapula back. And what I'm going to do first is pre-measure. Now, when I pre-measure with the posture tape or the coverall, I can pre-measure the exact distance. But when you pre-measure with flexible tape, you must know how much this tape stretches and how long you're going to make the piece, because that's going to determine how you measure this distance. If I measure it from here to here and I go to tape him, I'm going to end up way up here once I actually apply this thing with stretch. So knowing how far the tape stretches, and this just takes a little practice getting to know the tape, I'm going to back off about 25%. Again, fold your tape backwards before you cut it. Stick the scissors all the way in so you get as much of a clean cut as you can. All right, then you would do the same thing here. You're going to cut the corners, but I'm going to skip that for now just to kind of get through this here. All right, so this is essentially where I'm going. I'm going to be taping him right in this position with his scapula retracted with the intention of getting some feedback. But I'm doing this so you guys can see how much better using coverall is than using any kind of flexible tape. So there's a couple of different options. Some people will pull off the entire backing, then apply the tape. Some people will apply it from one end to the other. Don't be afraid of doing that. Remember, he's not going to feel which direction you applied the tape once you actually take everything off. So that's what I'm going to do. I'm going to go over here to the end, get my anchor on, peel off this midsection, come across the other side, and lay that down. And then when I push this midsection in, go ahead and retract your scapula a little bit. Yep. When I push this midsection in, that's actually what's going to give him that feedback of actually retracting once he protracts. So go ahead and let your scapula come forward. Can you feel the tape pulling you back?
Yeah.
Okay.
Yep.
Yep. Now you feel it all the time, correct?
In this position.
Yeah.
Yes.
So again, we have the same issue. Now, can you retract a little bit? Does the tape stretch ever go away?
About here, it goes. I don't.
Okay, so he's got to retract quite a bit. Now, I did put quite a bit of tape stretch on there, so I can modulate the amount of stretch. But you'll notice how finicky doing this is. I mean, if I tape this thing and I apply too much stretch, he feels the damn stuff all the time. I'll apply too little stretch. Go ahead and relax your shoulder blades forward. And let's get this right here. Let's apply too little stretch. Okay. And now protract. And you only feel it when?
Pretty much like here.
Right, so that's not useful. So I have to get the stretch exactly correct with this stuff. Here, now that I have a piece, you'll see how flexible it actually is. So here we go. This is at 0 tension. That's maximal tension. Notice it's only stretching about 2 or 3 inches, right? Very different than the K-tape. So where is dynamic tape useful, right? It's not ideal application for posture. This is useful for quote-unquote muscular support. So let's say for 1 second he had a periscapular strain. One great way to support this tissue is to line his periscapular region with strips of dynamic tape. So what I would do is I would have him retract a little bit, and I would set a strip here, here, and here. You put 3 of these things together in the same region, they're going to constantly pull back and offload the tissue that's here. How much? Probably just a little bit. But you want to know what? When this stuff goes on, people usually say, that feels so much better. But just bear in mind, because this is not a non-porous tape, the moment water gets underneath that stuff, it's going to want to come off, and they'll often tell you the tape only lasted a day. So that's why I love this coverall stuff. So what did we cover? We covered treatment intention, understanding that you have to understand whether you're doing a neurological treatment, a chemical treatment, or a mechanical treatment. That is going to determine which tape you use, what preposition you're using, and all that good stuff. We looked at breathable versus non-breathable and how that impacts duration of the tape. We looked at understanding that the large anchors are important for distributing force. We talked about preposition, understanding whether you are prepositioning on tension or on slack and how that impacts tape tension. We talked about taping in front of the axis or behind the axis, and we also discussed how tape direction really doesn't matter. We went over this finger tape job just to explain how you would apply a simple mechanical principle of anchoring and then taping on, and that's the finished product. Now you look like you were in a fight or something.
I got this one.
We talked about how we're going to use coverall for posture taping and how awesome coverall is. And to patients, we refer to it as posture tape because that's what we really use it for. Anti-flexion taping, anti-lumbar flexion taping, periscapular positioning, and just about any other body part that you are trying to give. So another good thing is anti-hyperextension of the knees. If you have patients who have posterior knee pain from chronically going into genu recurvatum, you can actually flex their knee a bit, put the posture tape on it, and get just amount of tension. It's usually about 5-10 degree pre-position of the knee. Put the tape on it with no stretch. They stand up. They don't feel the tape stretch until they hyperextend, and it's a reminder to not hyperextend the knee. So it's awesome. And then the last thing we did was we did the periscapular taping, and we looked at dynamic taping, tried to understand that the difficulty with flexible tape is trying to get exactly the right amount of tension when you're taping for something like that, but you can use flexible tape for some muscular support. Again, is it true muscular support? If you actually measured the torque, would it actually change anything? I don't know, but what I do know is that it does reduce patients' pain, and it does make them feel like they have more support, which is oftentimes useful, even if it's just in the acute stages of rehab. So if you guys have any questions, please drop them in the comments below. I love questions because it kind of drives our next topic, and we kind of shoot answers to questions, which makes for good videos. And if you're watching this outside of the PHYSIOSecrets group, if you're in the PHYSIOSecrets group, you're getting it first, you're getting it live. We usually put the replay out days later out on the PHYSIOSecrets page. So if you're watching it on the page, make sure to head over to the PHYSIOSecrets group, Clinical Mastery Made Simple, so that you can get this stuff when it first comes out. And head over to physiosecrets.com for some free content. And if you guys want to check out any of the courses, then they're all housed there. So that's it for taping principles and application. We'll see you guys next time, next Friday.
Later, guys.
Sometime in the afternoon. Peace out.